Hello, my name is Najimu Akanji. I'm a mental health nurse practitioner student here in NKU. I'm going to describe my most interesting client for the week. The patient is a 58 years old Caucasian female patient with a history of schizophrenia, PTSD, ADHD, and cannabis abuse. She was seen in the clinic 2 weeks ago for chief complaint of auditory hallucination, and she was prescribed Latuda 40 milligrams twice daily. Today, she reported to the clinic earlier than her scheduled time with chief complaint of bilateral lower extremity tremor. The patient stressed that she started notice increased tremor on her leg every night when she's going to bed. She stressed that as a result of this, she decided to reach out to the clinic. The patient is awake, alert, oriented to place, time, setting, and situation. She appears well built and properly dressed for age, gender, and setting. Her speech is clear and coherent. The patient reported recent low energy and poor concentration, denied poor appetite and insomnia. The patient reported occasional auditory hallucination. At the time of evaluation, the patient denies visual and auditory hallucination, denies suicidal thoughts and homicidal ideation. Verify with the patient to describe the type of hallucination she was having prior to the visit. The patient reported that she occasionally hears music playing to her head, to her ear by unseen, and sometimes she will be dancing to it as if it's real. Verified with the patient to describe the duration of her recent low energy and low motivation. The patient reported that low energy and poor concentration started 3 days ago. However, the patient denies poor appetite, suicide ideation, homicidal ideation. She denied using herbal products to cope with stress and depression. During the evaluation, the patient reported that she was diagnosed with schizophrenia 40 years ago. Diagnosed with schizophrenia when she was 40 years old. She stressed that she did not believe the provider at the time until her symptoms were prominent to the extent that she could not care for herself. And she admitted that she was admitted to an inpatient psychiatric hospital where she was stabilized with antipsychotic medication and psychotherapy. The prescriber utilized active listening, empathy, and silence to listen to the patient's concern. The patient said that she has never had any symptom related to EPS, but she's suspecting that the recent Latuda is the reason why she's having tremor. The patient denied tardive dyskinesia, denied drooling, denied lip smacking. The prescriber verified with the patient if the patient had any recent fall or head trauma. Patient denied any issue of recent fall and head trauma. The preceptor informed the patient that our current medication will be evaluated and changes will be made as necessary to promote treatment adherence. Verify with the patient if she does have any coping mechanism to cope with stress or depression. Patient reported that she smokes weed once in a while to cope with stress, but it does not help with depression. The professor and I encourage the patient to quit smoking and start engaging in moderate exercise to cope with stress and depression. Furthermore, the preceptor educated the patient that illicit substance use may compromise patient's health and can cause drug-to-drug interaction and food-to-drug interaction. Patients verbalized understanding of the teaching. Prescriber utilized GAD-7 and CRSS to rule out suicide and homicidal ideation. Patient denies suicide ideation and homicidal thought. Patient rated her depression as 9, verbalized mild anxiety, rated anxiety as 9. Patient thought process was logical and consistent. However, the patient appeared flat and depressed, and her mood was congruent with her affect. She reported that she occasionally don't take her medication. We strongly encourage the patient to continue taking her medication as prescribed. Patient current medication are Latuda 40 milligrams twice daily, Trazodone 150 milligrams at bedtime, Bospar 10 milligrams twice daily. The patient discontinued their congentin 0.5 milligrams for EPS. Started the patient on 2.5 milligrams twice daily. We strongly encourage the patient to continue taking all our medication as prescribed. Equally, the provider encouraged the patient to call a therapist to schedule a psychotherapy appointment. This particular patient case was of interesting because the patient reported that she used to work as a dancer at a local nightclub while she was in her 20s, and most of the music she does hear now when she's having auditory hallucination were related to the music she loved to dance to when she was at clinic. In conclusion, treatment adherence and appropriate discharge education that consists of drug-to-drug interaction, expected side effect, are what the patient should do in case they having increased in in case they having their symptom is getting worse, should be properly discussed with the patient before discharge. Thank you.